Welcome back guys. Now in this video let's discuss about normocytic anemias. Already we have discussed about microcytic and macrocytic anemias. Now in this video let's begin with normocytic anemias. Okay, so in this video I will be mainly giving you the basic idea, the introduction about the normocytic anemias. So the examples of the normocytic anemias will be dealt in the subsequent videos. See, normocytic anemias, what exactly we mean by normocytic anemias? Normo means normal size of the cells, normocytic, which means the size of the RBCs, the mean corpuscular volume of the RBCs is going to be somewhere between 80 to 100 femtoliters, something normal. Okay, so the RBCs are of normal size. But why there is anemia? Anemia is happening, but still the RBC size is normal. The RBC size is getting maintained. Okay, so that's what is the normocytic anemias. Now, why the problem, sir? So, normocytic anemias are mainly divided into two types. Okay, because of two reasons. One is peripheral destruction. Peripheral destruction, which means the RBCs are getting destroyed. Okay, the RBCs are getting destroyed. The production is okay, but there is some problem where the RBCs are getting destroyed very quickly. Normally for every 120 days the RBCs are going to destroy in the spleen, that's we know it. But here immature RBCs are getting destroyed continuously. So that's called as the peripheral destruction. Second problem is underproduction. Means the anemia is there because the bone marrow functioning defect, the bone marrow is not properly functioning, so there is underproduction of the RBCs, so little RBCs are getting produced. Okay, small amount of RBCs are getting produced, that too like the size of the RBCs is going to be maintained. Okay, underproduction, okay, bone marrow defect. So there is peripheral destruction as well as underproduction, both of them they can lead to anemia. Okay, so how to differentiate between them, whether the anemia is because of the underproduction or overdestruction. Overdestruction means the peripheral destruction, overdestruction or underproduction. How to differentiate between them? See, how to differentiate is based on the reticulocytes. Okay, so the reticulocyte count, it differentiates between underproduction and overdestruction. So what are these reticulocytes? These are immature RBCs. These are immature RBCs. Okay, so in the lineage we are having more blastic cells, immature cells. The immature cells will divide and forms reticulocytes, later erythrocytes. First reticulocytes and erythrocytes. So reticulocytes are one stage precursors for the mature RBCs. See, this reticulocyte count is going to give you an idea about whether the anemia is peripheral destruction anemia or underproduction anemia. For example, use your logic guys. Okay, use your logic. If it is a overdestruction anemia, where in the spleen there is overdestruction of the RBCs, RBCs are getting destroyed continuously, so the patient is having anemia. So what his bone marrow will try to do? The bone marrow will try to produce more and more RBCs, more and more reticulocytes. So reticulocytes are the ones which are going to convert into the RBCs. So what happened to the reticulocytes? Automatically increases. So keep this logic in mind in overdestruction or peripheral destruction. Okay, overdestruction conditions. In overdestruction conditions, the reticulocyte count, it increases. Okay, so if the reticulocyte count is more, means you can say, sir, this is a overdestruction is happening. If it is underproduction, okay, if it is underproduction, you can clearly say, so the reticulocyte count is going to be decreased. Underproduction means less number of reticulocytes are there, less number of RBCs are there. Okay, the bone marrow is not producing properly, so underproduction, so reticulocyte count is going to be less. Sir, how much more and how much less? See, usually in overdestruction anemias, the bone marrow is trying to compensate, it tries to produce more and more RBCs. Before RBCs, it have to produce more and more reticulocytes. So the reticulocyte count in the peripheral sphere is going to be more than 3%. If they mentions reticulocyte count more than 3%, yes, it is overdestruction anemia. If they say the reticulocyte count is less than 3% but still the patient is having anemia, it's a underproduction anemia. There is some bone marrow defect where it is not producing the proper amount of RBCs. Okay, so this is the reticulocyte count. Okay, one point, reticulocytes are used to distinguish between underproduction or overdestruction. Let me tell you what is something called as corrected reticulocyte count. Okay, corrected reticulocyte count. Corrected reticulocyte count and why it is important. See, usually what is a reticulocyte count? Usually how many number of reticulocytes will be there out of 100 cells? If you take 100 RBCs or 100 blood cells, 100 red blood cells, okay, see, out of this 100, 98, let's take 98 are the mature RBCs, 2 are immature RBCs, that is reticulocytes. Okay, 2 are reticulocytes. So what is the percentage of reticulocytes? The percentage of reticulocytes is 2%. 2 out of 100 RBCs. 2 out of 100 RBCs, 2 are reticulocytes, immature cells. Okay, immature cells, they are about to convert into mature RBCs, 2%. Okay. Now, for example, see what happens in anemic conditions, in anemias. Sir, in anemias, the reticulocyte count is going to be falsely elevated. It shows that reticulocyte count is more, okay, in anemias. So, how, sir? For example, see, normally out of 100 cells, 2 are reticulocytes, 2 are reticulocytes, okay, out of 100, 2 are reticulocytes, 2% is reticulocytes. But for example, 50 RBCs are destroyed, okay, because of some reason the 50 RBCs, the RBC count is coming down. Okay, let's put it this way, the RBC count is coming down, so maybe underproduction, let's take this way, say 50 RBCs, okay. Now, out of these 50 RBCs, 2 reticulocytes are there, okay, 2 reticulocytes are there, again here also 2 reticulocytes, but here, sir, the RBCs are going down. As the RBCs are going down, what happened to the reticulocytes? It looks like now the reticulocyte count is going to be 4%, the reticulocyte count is going to be 4%. Here also 2 cells are there, here also 2 cells are there, okay, here it is 2%, okay, but as you are decreasing the number of RBCs, reticulocyte count is the number of reticulocytes present in certain number of RBCs. Here the RBCs are going down. As the RBCs are going down, what happened to the reticulocyte count? It falsely elevates, okay, now it's not 2%, it's now 4%. So the point which I want you to know is, sir, in anemias, reticulocyte count falsely elevated. Now what you need to do? You need to correct it. Okay, you need to correct it, sir. So how can we correct the reticulocyte count? Okay, how can we correct the reticulocyte count? See, now what you need to do is take this reticulocyte count. Okay, a person came to you and now his reticulocyte count is 4%. Okay, 4 into divide by the person's hematocrit. Okay, now what is the normal hematocrit? The normal hematocrit is 45%. Normal hematocrit is 45%. What is a person's hematocrit now in our condition? The person's hematocrit, the RBCs came to half, from 100 it came to half, sir. So the hematocrit also come to half percent, for example 23. So now it becomes half, 1 by 2. Okay, 1 by 2, right? 23 divided by 45. It almost half. So 4 into half is equal to 2%. So this is the corrected reticulocyte count. Okay. So it's not 4% in the person. The corrected reticulocyte count is 2% only. It's a 2% only. Okay. So you need to calculate the corrected reticulocyte count, because reticulocyte count is the one which tell you whether it is underproduction anemia or overdestruction anemia. Let me show you the cell. So this is the reticulocyte immature cell. This is the reticulocyte which is a little larger in size when compared to the normal RBC, and it's going to have a little bluish in color. Okay, it's going to be little bluish in color when compared to the normal RBCs. Okay, usually the number of cells will be 2%. Okay, done. So after this, what I should teach you? Say if the corrected reticulocyte count, again at the end of the day, if it is less than 3%, marrow problem, under production. Okay, under production. If it is more than 3%, over destruction. Okay, underproduction over destruction to differentiate. Now after this, let's begin with peripheral destruction. Peripheral destruction, that is over destruction, the RBCs are getting over destroyed, peripheral destruction. Okay, so how many types of peripheral destructions are there? See, where the RBCs can actually undergo destruction, where they are undergoing destruction. See, the RBCs are undergoing destruction in the natural places like spleen, liver, lymph nodes. These are called as extravascular anemias, means the RBCs are not getting destroyed within the vessels. It's the extravascular, means within the spleen, within the lymph nodes, within the liver, in the reticuloendothelial system. Okay, so peripheral destruction anemias are divided into extravascular hemolysis, okay, extravascular hemolysis. So extravascular hemolysis means within where? Within the spleen, liver and lymph nodes. Okay, within the spleen, liver and lymph nodes. And where else? Where else the RBCs can be destroyed? The RBCs can be destroyed within the blood vessels itself. That's the intravascular hemolysis. So intravascular hemolysis means the RBCs are getting destroyed within the blood vessels. So that is within blood vessels. Okay, here within all these are reticuloendothelial system. Okay, these are reticuloendothelial sites. So the macrophages in the spleen, liver and lymph nodes are now destroying the RBCs. Unnecessarily they are destroying the RBCs. Okay, what are the examples of extravascular hemolysis? What are the examples of intravascular hemolysis? We will discuss later. But here the concept is peripheral destruction can happen in two sites, within the blood vessels, outside the blood vessels. Extravascular hemolysis, intravascular hemolysis. Okay, now let's see about the extravascular hemolysis. Okay, let's see here extravascular hemolysis. Who is destroying? The macrophages. The macrophages are destroying. Macrophages in the spleen, liver and lymph nodes are destroying the RBCs. Now, when the RBCs are getting destroyed, who is going to come out? Hemoglobin. Hemoglobin is going to come out. Okay, within the spleen, the hemoglobin is going to come out. So this hemoglobin is going to broken down into globin and heme. Okay, globin and heme cell. See, globin is a protein. Globin is a protein. So the globin will be broken down in the spleen into amino acids. The amino acids will be reused by the body. Okay, reused by the body. What about the heme then? You already know it. So heme is going to split into iron and protoporphyrin. Protoporphyrin. See, iron will be reused by the body. What about this protoporphyrin? So the protoporphyrin, it will be again broken down into a substance called as unconjugated. Okay, unconjugated bilirubin. Okay, in short form you can write like UCB, unconjugated bilirubin. It's a pigment. So this unconjugated bilirubin, which is a fat soluble thing, it will never come out of the body, fat soluble thing, it will go to the liver. In the liver, the unconjugated bilirubin, with the help of enzyme called as UGT, uridine glucuronidase transferase, the unconjugated bilirubin will be converted into conjugated bilirubin. Conjugated bilirubin. Okay, so now what I want you to know is, look here, there is over destruction, unnecessarily there is over destruction happening in the spleen. Within the spleen it is happening. So as it is happening within the spleen, okay, the hemoglobin is getting broken down into heme and globin. The globin will be reused by the body and iron will be reused by the body, and the protoporphyrin, lots and lots of protoporphyrin is getting converted into unconjugated bilirubin. The unconjugated bilirubin levels are getting elevated so much because of the over destruction. Now, do you think the liver is having a capacity to convert this lots and lots of unconjugated bilirubin into conjugated bilirubin? See, liver is having certain capacity, everything is having a certain level. Okay, for everything there is certain levels, certain capacity is there. Liver is also having certain capacity to do this conjugation, conversion of unconjugated to conjugated form. But now here there is too much burden on the liver. There is lots and lots of unconjugated bilirubin is coming. So liver capacity is exceeded. So in the blood you will have lots and lots of unconjugated bilirubin. Okay. Now this unconjugated bilirubin which is present in the blood is going to cause jaundice. Okay, so the patient is going to have jaundice. Icterus is going to be there, yellow color, skin is going to become yellow color. So jaundice symptoms are going to be seen. So at the end of the day, see this unconjugated bilirubin, liver is trying, right? Liver is trying to do it as much as possible, So at the end of the day, the unconjugated bilirubin is getting converted into conjugated bilirubin, but in a slow pace. But yeah, it's happening. So unconjugated bilirubin is getting converted to conjugated bilirubin. So now where this conjugated bilirubin will go? So it's going to where? Gallbladder. Even normal conjugated bilirubin also will go to the gallbladder and is getting secreted in the bile. Okay, but now in this condition, lots and lots of conjugated bilirubin is also there. Now this conjugated bilirubin in the gallbladder is going to precipitate. The conjugated bilirubin is going to precipitate and is going to bind with the calcium ions, forms calcium bilirubinate. And this calcium bilirubinate is the one which forms the stones. So the patient is going to have gallbladder stones, cholelithiasis. So understood? Now a patient who is having excessive amount of hemolysis, where hemolysis also? Extravascular hemolysis. He is going to produce lots and lots of unconjugated bilirubin. That unconjugated bilirubin is going to cause a jaundice, and the unconjugated bilirubin will be converted into the conjugated bilirubin, and this conjugated bilirubin will bind with the calcium and forms the gallstones. These patients are at risk of developing gallstones, and these gallstones are pigmented gallstones. These are not cholesterol gallstones, these are pigmented. Okay, these are pigmented gallstones which are usually black in color. Okay, cholesterol gallstones are yellow in color. These are the pigmented gallstones. So pigmented gallstones are seen in which condition? Excessive hemolysis. Okay, excessive extravascular hemolysis, especially hereditary spherocytosis, sickle cell anemia, that I am going to discuss in the later videos. Okay, so this is done. This is completed. So what are the laboratory findings that you will see in these patients? Laboratory findings in extravascular hemolysis. Clinical features I have explained you. What are the laboratory findings? The laboratory findings are going to be, yes, of course the patient is having anemia. Okay, anemic features are going to be seen, anemia, hypoxic features, easy fatigability, these things are going to be common. See, more hemolysis is happening where? In the spleen. So spleen is doing more job. Okay, spleen is doing more job. So spleen will undergo hypertrophy. So splenomegaly. Okay, the spleen is going to undergo splenomegaly. Splenomegaly is going to be seen, anemia is going to be seen, and next what else I want you to know is, okay, hemoglobin levels will come down, and last thing is reticulocyte count. See, here what is the problem? Over destruction. There is no problem with our bone marrow. Bone marrow is perfectly normal. There is over destruction. In the spleen there is over destruction happening. So what about the reticulocyte count? The reticulocyte count is going to be more than 3%. It's going to be more than 3%. So extravascular hemolysis is completed. Next, let's discuss about intravascular hemolysis. So intravascular hemolysis means what? RBC destruction happening within the blood vessels. Within the blood vessels because of some reasons. I will tell you later what are the examples and why it is happening. Because of some reason within the RBCs itself, within the blood itself, vascular system, the RBCs are getting totally destroyed. Hemolysis is happening. So that is intravascular hemolysis. So if there is intravascular hemolysis, okay, so let me write here hemolysis within blood vessels, not in the reticular endothelial system, within blood vessels. What happens, sir? What are the things you can appreciate? See, now the RBCs are not getting destroyed in the spleen, not in the splenic macrophages. So if RBCs, if they are destroyed within the blood vessel, let me tell you what happens. Hemoglobin is going to come out. So hemoglobin, it's actually a very bad substance, sir. Okay, it will cause nephrotoxicity. Okay, it will cause nephrotoxicity. It can cause a lot of unnecessary problems. Okay, and hemoglobin is also it's a very important thing for our body, because hemoglobin contains iron. We are not supposed to we can't lose it. Okay, we can't lose it. So the moment RBCs are getting destroyed within the blood vessel, the hemoglobin, whatever have came out, is going to bind with a plasma protein. It's not freely circulating. It's going to immediately catch up by a plasma protein, sir. What is that plasma protein called as? Heptaglobin. Okay, heptaglobins. So now tell me, what happened to the heptaglobin levels? Sir, as there is more and more hemolysis, hemoglobin is leaking, so hemoglobin is going to bind with the heptaglobin. So what happened to the heptaglobin levels? So serum heptaglobin levels goes down. The free heptaglobin levels will go down, sir. Okay, it's going down. Second thing, as the heptaglobin is not available, now the free hemoglobin, now heptaglobin levels are going down. So now we are having what? Free hemoglobin. Now where it will go? The free hemoglobin will go to the kidneys. Now it's going to filter over there. So the hemoglobin is getting filtered into the urine, and the hemoglobin is going to come out in the urine. Okay, so initially what the patient is having, the hemoglobin is present in the blood. Okay, hemoglobin is present in the blood. So that is hemoglobinemia. Okay, hemoglobinemia is there. Hemoglobin is present in the blood. Hemoglobinemia is there freely. Now, second thing, this hemoglobin is getting filtered into the kidneys and going out in the urine. So, hemoglobin urea. The patient is going to have red color urine, hemoglobin urea. Okay, so patient is having hemoglobinemia and hemoglobin urea. Okay, hemoglobinemia and hemoglobin urea are going to be seen, sir. Apart from this, see, the patient is also going to have hemosideruria. Okay, hemosideruria. Okay, so what is this hemosideruria? Is, look here. So this is your nephron. Imagine this is your nephron, the proximal, the Bowman's capsule, and this is the proximal convoluted tubule. Now hemoglobin is coming here. We cannot simply lose the hemoglobin out of the body, because hemoglobin is rich in iron. Hemoglobin is having iron. We cannot simply lose the iron out of our body. So the hemoglobin is getting reabsorbed into the PCT epithelial cells. Okay, let me put it this way. Let me show you. So these are the PCT epithelial cells, the lining cells in the PCT, proximal convoluted tubule. So hemoglobin will be reabsorbed into the proximal convoluted tubular cells. Now there the hemoglobin is going to be broken down and the iron is going to be released. So here iron is there. Okay, iron is getting accumulated here. Okay, after some days what will happen? So every cell will be having some turnover. So these old cells, they will be denuded, they will be sort of, and they will be coming out in the urine. Okay, so turnover will be there, right? So because this iron is getting accumulated inside the cells, so these cells with iron is coming out in the urine. So now these cells, what they are having? The irons are hemosiderin. Okay, the hemoglobin is broken down into hemosiderin. So hemosiderin is nothing but the iron. Okay, iron pigment. So these cells are coming out. So the hemosiderin is present in the urine. So hemosiderin urea. So what are the important things which I want you to know? If there is intravascular hemolysis, there is hemoglobinemia, hemoglobin urea, hemosiderin urea, and the serum haptoglobin levels are going to go down. Okay, the serum haptoglobin levels will go down, sir. Okay, and what about the reticulocyte count? So the reticulocyte count, here also over destruction, there is no problem with the production, over destruction. Here also the reticulocyte count is going to go more than 3%. Okay, it's going to go more than 3%. Okay, so these are the important points which I want you to know. The hemoglobin is directly present in the blood. The hemoglobin is going to the kidneys and there it's getting filtered. So hemoglobinemia, hemoglobin urea are going to be same. Okay, so this HbH is again going to go to the hemoglobin heptoglobin complex. It's going to again go back to the spleen, where the hemoglobin will be properly processed, properly broken down. Okay, so even these patients will have a mild degree of jaundice symptoms can be seen, but main important point is serum haptoglobin levels will go down. In both the conditions, that is extravascular hemolysis or intravascular hemolysis, it doesn't matter. The reticulocyte count is going to be, the corrected reticulocyte count is going to be more than 3%. Okay, so with this, the basics about the intravascular hemolysis and extravascular hemolysis are completed. Now in the next video, we will be discussing about anemias where there is extravascular hemolysis and where there is intravascular hemolysis. Hope the video is helpful. Thank you.